And they were randomized to either get ablation pulmonary vein, RF ablation, or medical therapy with 12-month follow-up. And this is the results presented. These are the results presented, which does show there was benefit of ablation over medical therapy, but the success rate is not great. It's in the low to mid 60% range out at 12 months. And there is a 30-day blanking period during which time the patients could actually undergo additional RF ablation, which some found fault with, but that is not an unusual methodology utilized in this type of management. So it was more effective than medical therapy, and they were lower, and probably they were lower success rates than some of the other percutaneous treatments for AF, in part related to the fact that they did have persistent AF patients in this trial. They are very ambitious in trying to enroll 3,000 patients at 180 centers worldwide and look at defined mortality and stroke issues with this. This is another very interesting AF trial. This was the RACE-2 trial presented by Isabel Van Gelder, looking at 614 patients, and the question was, does it matter what rate we drive the AF patients down to? If we're not going to try to correct the dysrhythmia, is it better to let their heart rate stay 110 or better, or should we get it below 80? And so they divided the patients into two groups. They called them the strict or the lenient treatment groups. And interestingly, there was no increase in heart failure observed in these patients. These patients had to have been in AF for 18 months before they were enrolled in the trial. A surprising finding was the fact that there were more adverse outcomes in the strict group, possibly related to the fact that many of them didn't tolerate the medications, because they did push the medications, sometimes up to 3 or 4 different drugs, to very high levels, and that gave rise to some significant adverse events. But the question was answered. It didn't seem to matter if you kept the heart rate 110 or about that, or less than 80. The symptoms were pretty much equal in both groups, both during the trial and at the end of the trial. Another issue that was discussed in the AFib trial was anticoagulation related. And obviously, we're looking for a better anticoagulant than warfarin, even though it's an inexpensive agent. It's got such a narrow therapeutic margin that 10A inhibitor medications are being looked at. And this was the Explore 10A trial presented by Dr. Eskowitz. And it was a pilot study using 3 different doses of 40, 60, or 80 in chronic AF versus warfarin. And they followed these patients for 12 months, and they had excellent follow-up. And the size of the study was reasonable. It was about 500 patients, and they had very good monitoring of the rhythm and other issues. And interestingly, there was no difference in any of the events except that there was less bleeding in the 40 milligram dose of betrixaban compared to warfarin, compared to the higher dose, and there was no difference in the small study group, probably not powered highly enough to say that we can go with this yet, with the betrixaban versus warfarin. So this study is now going to be expanded, and maybe we'll have a medication that we won't need to do INR monitoring or other such monitoring, which is obviously something we're looking for. There were some very notable abstracts in the dysrhythmia groups. One of them was looking at, this was a great idea, analysis of 900 ICU patients' EKGs for QT interval issues. And in critically ill patients, over 900 admissions reviewed, 40% of the patients were given a drug that prolongs the QT, and they were given a QT prolonging medication on admission to the ICU. So there we have to pay attention to all aspects of the database of a patient when we manage them, so that we don't actually cause a little more down trouble with adding more pharmacy that may cause more trouble. And the QT prolongation in HIV-infected patients was directly correlated with viral load and decreased CD4 counts. There was an interesting session that was quite popular that we decided to do this year with a lot of collaboration from many individuals. There happens to be a cardiologist who's also a professional airline pilot, and he was an interventional cardiologist before he became a professional airline pilot, and he's now working part-time. We're all looking for better ways of simulation and education and proficiency evaluation. And this individual led a simulation drill where we actually set up a cath lab and an emergency room and had participants role play as the ER physician, the doctor, the nurse, the cath lab individual, the cath lab technician, and all sorts of variables were thrown in there that would maybe make the process not as smooth as one would want. And the design was to see how you reacted to these issues. And they were filmed, and they were then reviewed with the audience. And then, for real-world sake, we actually had a small hospital, a 180-bed hospital, that has a door-to-balloon time of 60 minutes, which is pretty amazing. And they actually allow the paramedics to send an EKG, sometimes over a cell phone, with a picture, which they text message, over to the ER doctor, who has the authority to call the cath lab in based on that. And they're very motivated to get the door-to-balloon time down, and they've succeeded there. And a large inner-city hospital with a teaching center and a very complex neighborhood in terms of demographics, how they succeeded. And we learn from each other how we can succeed in improving care in our area, because we all have logistic issues that can affect our ability to do things. Yet when we hear how others have overcome some of these obstacles, it sometimes gives you a little ammunition when you go to a hospital administrator and say, well, geez, I think we can improve this aspect of management, and it's been done in another way. And this was a very popular session, and it ran every day. Myocardial ischemia infarction was an interesting session, and this was led by Kristen Newby as the topic coordinator. There were several key themes this year in myocardial ischemia. One is looking at clinical guideline implications in revascularization, particularly non-STEMI invasive versus conservative care, STEMI infarct-related target versus complete revascularization, and there were multiple abstracts and several key LBCTs that we'll talk about. But in general, it seemed that there was better survival and less cardiac events with the more aggressive approach with complete revascularization, but there was more contrast nephropathy. And we're also looking at novel biomarkers, and high sensitivity troponins was an interesting discussion. One of the large retrospective reviews was a long-term outcome of routine versus selective invasive strategy in patients with non-ST segment ACS, and this was actually presented at one of our combined sessions with the British cardiology team and the ACC, and it's called the FIR trial because it looked at each individual patient in the Frisk, ICTUS, and RITA trials, so FIR. And it was presented by Keith Fox, and it was quite a sizable undertaking, 5-year incomes looking at the impact of routine versus routine versus selective invasive in all patients who came in with a non-STEMI. And the invasive strategy included early angiography with PCI or CABG, and they described early in the manuscript as within hours up to 24 hours. Selective invasive strategy was in presence of refractory angina only if they were managed with medicines and failed. And this shows the interesting conclusion is that routine invasive strategy reduced cardiovascular death, or MI, at long-term follow-up out at 5 years. There was a 3.2% absolute risk reduction, but a 19% relative risk reduction. And very importantly, if you look at the risk stratification of the non-STEMI patients, the high-risk patients in the bottom right of the slide had a 11.1% worse mortality. So we can identify some of these patients as high-risk patients and perhaps intervene or catheterize earlier if it's not possible to catheterize everyone with non-STEMI. And this looks at some of the other breakdowns. The cardiovascular death, or MI, selective versus routine, was improved for all of those 3 factors. And another thing that might help us risk stratify patients, if we're able to come to an ability to agree upon the right test for this and the cost isn't prohibitive, is the highly selective troponin study. This looked at patients who underwent evaluation for acute coronary syndromes and looked at their mortality, short and long term, based upon their troponin when they came in the door, their highly selective troponin. And I'm sorry that it's not projecting real well, but the best survival is actually the top line, which is the lowest highly selective troponin, which makes sense. But most interestingly, the next best survival curves in both is actually the high-level troponins. And if you look in the far right, down bottom on this, it turns out that the patients who had the highest highly selective troponins wound up getting the most aggressive catheterization. And got the most aggressive medical management. So it turns out those patients actually had already been selected to get more aggressive therapy, both medical and interventional. So there is a message there that perhaps we can utilize this to help us improve our care for patients with acute coronary syndrome and infarcts. In terms of evaluating risks, there are many novel biomarkers that are being looked at for chronic coronary artery disease, chronic ischemia. None of them are ready for prime time yet, but those are 3 groups that are being looked at, and there are presentations on all 3 of them that look promising. We did have a wonderful presentation as the annual Masiero Florio International Lecture by Dr. Bassan, who spoke on improved outcomes without excessive bleeding in acute coronary syndromes, a dream come true. And that was a very popular discussion and review of the current state of affairs with all the different agents we have, where we're going, and how we want to finely tune things even further. And obviously coming down the line will perhaps be the ability to better customize the therapy we use for each of our patients in terms of their reactivity to certain agents, which is obviously along the lines of functional genetic testing. And there are ways of doing some of these tests now relatively acutely in the cath lab. General cardiology, hypertension, prevention, and lipids, and prevention should be underscored for all of us. That's obviously a key thing that we all can do better on with our patients in our communities. And one of the large studies presented was the ACCORD study, which was the effects of intensive blood pressure control on cardiovascular events in type 2 diabetes mellitus, the action to control cardiovascular risk in diabetes, which was an attempt to do a couple things. Look at high-risk patients for developing cardiovascular disease and try to change that by doing certain things in addition to just lifestyle. And one of the issues was blood pressure strategy, to drive the blood pressure to lower than 120 versus drive it just to 140, and also to see if we could alter progression of disease or development of disease in addition to adding lipids using fenfibrinate. Now, they were very successful in getting the blood pressure down, which is quite an achievement. They were able to sustain this significant blood pressure decline for out to 8-9 years. And that's a significant achievement. So they were able to drive the blood pressure to goal. But very interestingly, there was no significant difference in mortality for patients with this, or cardiovascular events primary, being cardiovascular death or MIs. However, they did decrease stroke significantly. The stroke, both non-fatal and fatal strokes, were decreased with blood pressure lowering. And that is a significant issue, but it perhaps does make some sense. There have been similar issues reported in the past about this. Now, there was a second arm of this that was presented by Henry Ginsberg, which was looking at the lipid aspect of it. And fenfibrinate versus placebo was added to statin in 5,518 diabetics. Interestingly, the entry triglyceride level in these diabetics mean was 162, and their mean follow-up was 4.7 years, and there was no benefit in adding fenfibrinate to these patients, which was a surprise to the investigators, except if the diabetics had high triglycerides at entry. And it wasn't statistically significantly better, but there was a trend towards improvement with the high triglyceride patients to add fenfibrinate. The Navigator trial was the biggest trial presented. It was over 9,000 patients, and it was evaluating, looking at whether or not valsartan